Hello everyone. We have a 54-year-old man who complains of bitter taste and substernal burning 30 to 40 minutes after meals. The burning is relieved with antacid and worsened by lying supine. Food gets stuck in his chest if he doesn't chew properly. There is unintentional weight loss, significant weight loss. He has a 40 year of smoking history, 40 pack years. Now, what is the most appropriate next step in the management of this patient? Well, before I discuss this question, I want to ask you, what the significance of positive GIT test in any patient? Stop the video, write down the answer. Well, the significance of this is bleeding is occurring in the upper GIT above the ligament of treats. You should know the anatomy, where we talk about. We have a ligament, suspensory ligament of treats, which unites duodenojejunal flexure to the right crus or diaphragm. So if the bleeding occurs anywhere here or in the stomach, we call as upper GI. If it is below, we call as lower GI. Normally, if the upper GI bleeding occurs, it is black tarry, what we call as melena. It is black, tarry, and very offensive. But in lower GIT bleed, it is usually fresh blood is there. Fresh bleeding is there. Well, as far as our question is concerned, the correct answer is D, upper GI endoscopy. Patient presentation is consistent with typical GERD, that is gastroesophageal reflux disease. Okay, why patient need to do endoscopy? For a reason. First of all, the age is 54 year, above 50 year, we always like to go for endoscopy. Bitter taste and substernal burning sensation 30 to 40 minutes after meals. That means a big problem. It has come up to bitter taste. The reflux has come up to the mouth. Burning is relieved with antacid and worsened by lying supine that contribute to diagnosis of GERD. Unintentional weight loss. In the past 3 months, it's a fairly large amount of weight loss is there. Dysphagia, notice that food gets stuck in the chest, and tobacco use. Patient has 40 pack year of smoking. So let us see how we approach a case of GERD in the management. Well, it's a full screen is there, and its font is small. So I'll be showing you this slide in broken form in the next 2 slides, so that I can tell you much better, I can show you much better. So frame 1. We have a symptom consistent with GERD like in our patient. So then you evaluate. Patient age more than 50 years? Yes, our case is a 55 year. Or symptom for more than 5 years? Or cancer risk or alarm symptom? What are the alarm symptom? I'm going to discuss in the next slide. Yes, perform endoscopy. Like in our case, we got many features which are consistent with. Okay, so we like to go for endoscopy. But if it is not, then simply try with proton pump inhibitor for 2 months. That means indication of doing endoscopy is dependent on whether we need to do, problem is there or not. But in our case, definitely we like to do. But I'm reminding you, if no, then simply give proton pump inhibitor. And if despite giving for 2 months, that's a refractory symptom, then we have to proceed further. And here we have done endoscopy. What finding we are getting into this? So let's talk about this case where refractory symptoms are there. In such cases, switch to different PPI or increase PPI twice daily. Previously, we were giving once daily. Now we have increased the dose or change the other PPI. Symptom control continue. If persist symptom, then you go for endoscopy or esophageal pH monitoring to be done. Okay, this is how what we are going to see. Now let's see other way around where we have these features like in our case and we have done the endoscopy. In endoscopy, you are getting no esophagitis or esophagitis. If you are getting esophagitis, to treat according to diagnosis, pill esophagitis, Zoringer-Ellison syndrome, eosinophilic esophagitis or Barrett esophagus. If no esophagitis, then you go for investigation, achalasia, gastroparesis, non-acid reflux disease, nocturnal acid breakthrough. They are the other thing that should be taken into consideration. And after that, depending on the clinical situation, you can go for esophageal manometry, impedance testing or gastric scintigraphy should be done in where we are not getting esophagitis. So this is how you have to approach. Now let us see, we talk about alarm symptom where we wish the physician or treating doctor should be get alerted, melena, that indicate upper GI bleed. Persistent vomiting, hematemesis, weight loss, anemia, dysphagia, odonophagia. These are all alarming, raising. In the case of GRD, we have to be very, very alert. That means the matter is a serious matter. So we are clear about it, what all to be done, and why, how we have to approach a case of GRD. Let's look into the other option. Esophageal manometry and esophageal pH monitoring. I covered this point. They are to be done not in all cases, only in these cases where we need no esophagitis, and in such cases we have to do this investigation. The point I discussed, I don't think I need to repeat again. Helicobacter pylori stool antigen testing. This can lead to gastric or duodenal ulcer. We are well aware. Testing is indicated in patients with active or past history of peptic ulcer disease. Routine screening and empiric treatment for H. pylori infection may also be considered for patients who have dysphagia but not GERD. Now, I have one question for you. H. pylori can cause which malignancy? Stop the video, write down the answer. It can lead to gastric mucosa associated increased risk of gastric adenocarcinoma and MALT lymphoma, low-grade B lymphoma is the right answer. Golden line to remember, patient with typical GRD symptom require an upper GI endoscopy if they have alarm symptom like dysphagia, odonophagia, weight loss, anemia, GI bleed, men over 50 years, or chronic cases more than 5 years of symptom. Increased gastric risk factor like tobacco use. All other patients can receive empiric trial of proton pump millimeter therapy and further evaluation if refractory to therapy. Thank you very much.